Dr. Winter.
Now, Dr. Winter, you're still under oath.
Dr. Winter, you'd been telling us yesterday about the decision that you made in relation to heat-treated products in the middle of 1984. And in your statement, you say of that decision, no patient since that time was infected by any virus at our centre. I just wanted to ask the basis upon which you're able to say that. In relation to HIV, and you may well be right, I'm not seeking to challenge your conclusion, what's the basis for your ability to be confident that no one treated at the centre with heat-treated concentrates from May 1984 was infected with HIV? Because you weren't able to do the historic exercise because there were no stored samples under your predecessor.
Yes. So, I mean, I'm talking about the major viruses that we were dealing with, hepatitis B, hepatitis C, HIV. I mean, of course, that remark is in the context of, as we discussed yesterday, it turns out that all but one of my patients had HIV already, and all of them presumptively had hepatitis C already if they'd been previously exposed to concentrates in the years prior to that. And, of course, they were screened regularly for hepatitis B, and they were vaccinated against hepatitis B. So there was no patient in our centre, and as far as I'm aware, we were obviously particularly close to St Thomas's and their information as we were part of the same regional network. I wasn't aware of anybody becoming HIV positive or hepatitis C positive subsequently who'd previously tested negative at the time of the change. Of course, it's in that statement it's important to stress there were very few patients left who could seroconvert because most of them had been infected anyway. Obviously, in my statement, that would not include sort of minor viruses like parvovirus, which we couldn't or didn't test for. I didn't know or wouldn't know whether the heat-treated concentrates transmitted that, but that was a pretty low-profile virus. Of course, it did turn out, and this is an important point, you'll understand the reason for the change was based on theoretical concerns, not on any sort of very solid science. And there are papers we may look at later, which later than this date did show that heat treatment did indeed inactivate HIV, as the experimental work had suggested. But it also turned out, very importantly, that this first generation of heat-treated products, which didn't heat for very long or to a very high temperature, in the end did not seem to inactivate hepatitis C. So this was the first time an attempt was made to make treatment safer, and we now know it did make treatment safer, really importantly for HIV. But it turns out that if you did switch to heat treatment and you at that stage did not have hepatitis C, you might still have been vulnerable to get hepatitis C.
You, I think, wanted to make some observations about the UK HCDO's publication, the AIDS advisory document in December 1984. We can put that on screen. Henry, it's HCDO 0000 270 _007. So it should come up before you.
So it seems to me this is a really sort of important document because it's coming at this very critical time. Is this December 84?
December 1984.
Yeah, so most centres will have had their HIV results a few weeks prior to this. And we spoke yesterday of the very unexpectedly high level of positivity, which nobody had really expected. So there's this very strong sense amongst doctors like me, suddenly it's apparent we're in a major health emergency in the haemophilia world, adjacent with what we already know about severe chronic liver disease, the evolving story. So now we have two major problems, and this isn't a minor thing, as some haemophilia doctors have predicted. This is going to be a major healthcare problem, and how do we deal with it? So this is not the whole of the haemophilia directors. This is the reference centre directors. I don't know whether this could have been a scheduled meeting, because they meet every 3 or 4 months, and they've got there where it says in consultation, these are some blood transfusion experts and virologists, and particularly they've got Richard Tedder and John Krask as virologists there. So they start by reporting the current state of play, that there are 3 haemophiliacs, and then it stresses to haemophilia doctors the availability of the tests, which now also include the PHLS. I mean, by now, most of the centres should have done the tests, but we know, I think, that that wasn't always the case.
We do know that, yes.
Yeah. Can you go next page? So then they, as we've just been discussing, they then talk about this research evidence, laboratory evidence, that it seems like HIV might be susceptible to heat, some spiked concentrate. So what that means is if somebody's taken factor VIII concentrate and spiked it in the laboratory with HIV and then heated it and then shown that the HIV is inactivated. So that's something that proved to be true, and then exactly as I've been saying, it is unlikely that this process completely inactivates non-A, non-B hepatitis. Absolutely correct. Something we haven't discussed so far, another problem about heat-treated, was that you get less factor VIII out of the manufacturing process. So not only was it 50% more expensive, but you lost a bit of factor VIII in the manufacturing, which was another sort of slightly minor factor about switching to heat-treated. And then it talks about the dry heat-treated product and tells you the price of it. And by now, since the alpha, which the one we used had come in the April and May, now you see that last paragraph under factor VIII, there are now several heat-treated, these are all commercial, all American plasma, but all heated in various ways. There were 2 ways of doing it. There was dry heat or wet heat. I'm not quite sure what the difference was between dry heating and wet heating.
I think the difference, as I understand it, but you may not have understood it that way at the time, is that wet heat is pasteurized. So you have the virus in solution. Dry heat is after the product has been freeze-dried,
Right.
and the heat is then applied to phials of freeze-dried concentrate. And I think there is a third intermediate where the freeze-dried concentrate is diluted a bit in a solvent, so it is somewhere in between the 2. But those, I think, as I understand it, are the 3 different production methods available at the time, if that's any help.
Well, it is. You know a good deal more about fractionation methods than I seem to. So
Well, I'm only taking it from what I've picked up.
That is very helpful. Now, BPL halfway down or towards the end here. So BPL is being rebuilt. All this money's gone into it, but it can only dry heat at that stage 30% of its output from January the 30th. These dates are really important. So this is about 8 months after some of us have switched to commercial dry heat. BPL, 8 months down the line, can still only dry heat 30%, but more coming, as promised. And then we know about Scotland. And then they talk about recommendations for doctors as to what they think they ought to do. And as you can see here, they're really...
You have the rest of the page, Henry. Thank you.
Where I'm talking about options in decreasing order of safety, they're still recommending concentrate. You know, the haemophilia directors never prioritised a switch back to cryoprecipitate at any stage, and in any case, we know that there were not the supplies of cryoprecipitate to do that, but they do under option 2 suggest that you could use some cryoprecipitate.
Just pausing there, Dr. Winter. We're told this is in probable decreasing order of safety. So it does seem as though that their first priority was the heated UK concentrate, but as you've already observed, comparatively little of that available at this time.
Yeah.
Single donor cryo or FFP is then prioritised in order of safety in this document over imported heat treated.
Yes. But we discussed all the problems around cryo usage and the very significant problems with it, and we've also discussed the supply problems. Certainly in, the Tooting, as we discussed, the Tooting Centre could not put out supplies of cryo to any significant level, although, as you said yesterday, in other parts of the country, like Southampton, supplies of cryo appeared to be greater. But this is an important document because they're clearly saying to doctors, reinforcing that it is better to use heated than unheated, because this is at a time when an awful lot of centres have not gone across to using heated. And they're saying, as you would expect, that UK concentrate heated, if you could get it, a key phrase, was a lot better, or was better than heated imported. This is a snapshot in time. All this is going to change radically over the next few months. And then again, these key phrases at the bottom. Concentrate is still needed. Bleeding is the commonest cause of death and disability. So we've heard of these calls. Why could factor VIII therapy not have been suspended? Well, in the view of the clinicians, it could not have been. They used DDAVP, we've talked about already. Can we go on to... And then they talk about what used to be called the virgin, the pups, how to treat them. That's pretty uncontroversial. And then the using heat-treated. And then for haemophilia B, I'm just reading the evidence lower down, the evidence that heated US factor VIII is safer than unheated NHS is debatable. So this was at the core of the argument. After all the things we said yesterday, I got home last night and I remember a meeting. Professor Bloom said to Dr. Savage and I, "You are mad to switch. There will never be HIV in BPL factor VIII."
Can I just ask you, do you have very useful evidence to know, do you have any recollection roughly when that meeting would have been?
It was at a scientific meeting. It was outside of the meeting.
Yes. In the course of 1984?
Yes. He actually, when he learnt that we were going to switch, he actually came up to us and said, you are mad to do this. It's completely unnecessary. That this is not going to be a problem in BPL factor VIII, as we'll see from other correspondence of Professor Bloom. So there was this major split of haemophilia directors for all the reasons we talked about. One camp saying, I'm terribly worried about this data. Haemophiliacs are so vulnerable. We now know it's a virus, increasing number of patients in the US. Plus by now, we don't have the testing data yet, but we're going to switch. But we do have the testing data by the time of this document. And then this counter-argument, this is only a problem for American factor VIII. It's not going to happen in British factor VIII. Look at the Germans, they use twice as much as we do. They've had no problems. I'm really worried about inhibitor formation. I'm just going to monitor the situation. So there was this, split up, probably in Britain, 20 major treaters. There was about 4 to start off with, and then a few more, and a hard core of sort of 10 to 12 with a totally opposite view. So for the next few months, there is this complete, it's like Brexit, okay, just leavers and stayers.
And then I think if we go on in this document, well, if we just look there, it says in individual patients, there may need to be a choice. In general, heated concentrate appears to be the recommendation of virologists consulted, but individual directors may wish to make up their own minds. This is particularly true of unheated NHS material, and then the passage you've referred to. So it would appear from this document that although this is much more detailed advice than anything previously published by UKHCDO, the idea of clinical freedom, which you referred to yesterday, still appears to be represented in that passage. Would you agree?
Well, I would. I mean, if you read all the Haemophilia directors' minutes over the 10 or 15 years, the phrase individual directors may wish to make up their own minds occurs again and again and again and again. And now, in medicine, of course, it's not like that. You have standardized protocols which are issued to doctors and they're expected to follow them. But there was this sort of ambience, if you like, of working as a haemophilia director where the function of these bodies was a guidance which steering you, as they are. They're saying what we think or what the virologists think, but actually at the end, it's down to you.
And I think you have also observed yesterday that there was something in this document about testing. So I don't know if we just carry on further down. Is there anything before we go to the next page?
Yeah, so...
Is there anything before we turn to the last page which deals with testing that you wanted to comment on?
So I'm just looking at section 2 there. We spoke about this 50% jump in price and all the problems that caused. I think, again, that, you know, a number of directors would have looked at that and said, how am I going to get the money, you know, at the start of a NHS financial year? I'm never going to be able to do it. I think that was another deterrent. Funding will need to be negotiated at local level, correct? And that's what it was like. I think we can go to the next page. So antibody testing. It is recommended that patients be tested. Does not say anything at all about pre-test counselling. This was not a concept in clinical medicine at that time. And then it says quite rightly, well, firstly it says people should be informed, quite rightly. Then the use of a very strange word, reassured. On what basis did they feel able to say, you are testing positive, but there's nothing to worry about? That seems an extraordinary word to use. Counselled regarding transmission to spouses, of course that's important. This seems to be the most practical method available. So here we are, it's clearly saying for the first time to doctors, you must treat, if, you know, most people should have treated already, most of us had, and this is the way to do it. Could we get, is there anything else later on?
The rest of it deals with arrangements for the care of, so if we go under the heading clinical, so it's personal protective equipment, topical issue, and arrangements for nursing. Could we just go to the very top of that page, please, Henry? We can see there at the top of the page, there's also a point about assessing the need for elective surgery in the light of supplies of heated concentrate. This appears to be the first time that UKHCDO make any reference to that. I think you told us yesterday that in your own practice that was something you'd already considered.
I mean, all these changes are happening against a context of doctors trying to not use concentrate unless they had to. So you probably talk about prophylaxis programs being suspended, making sure that patients were using concentrates in the home setting only when it was very strictly needed, making sure they absolutely understood when they should and should not be giving concentrate, avoiding concentrate in mild patients and von Willebrand's, as we discussed yesterday, and haemophilia carriers, and then also looking at surgery. You know, if you had a patient who had a hernia that had been there for a year and needed doing, but from which he was not getting major symptoms, you would be inclined to say to him and the surgeon, I really don't think we should go ahead at the moment. You know, your symptoms are not major, and I really think we should put it on hold for a few months and see what the situation looks like in a few months' time. So this was one of the devices, if you like, that would be used to minimise risk.
Now, we know that this document, which is dated the 14th of December 1984, arose out of a meeting that took place on the 10th of December 1984. There is just one issue in relation to that meeting I wanted to ask you about, so I'm going to put that on screen. HCDO 40 394_117. 117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. 394 _117. And it's about the issue of telling patients the test results. So I won't go through the thrust of most of the meeting. You can see there it was a special meeting that was arranged on the 10th of December 1984 to take place at Elstree. Henry, could we go to the 4th page, please? And if we go towards the bottom of the page, second half of the page, after the reference to Dr. Jones, there's a paragraph which says this: a long discussion took place on whether persons found to be positive were to be informed. Several differing views were expressed. It was agreed that each clinician would decide for each case depending on the facts of the case, but in general to provide information if asked for. And then if we go to the next page, please, Henry. Halfway down, there's a passage saying the chairman, that we know was Professor Bloom, summarised by saying that testing should be instituted as soon as possible and that information on the test results should not be given automatically, but if asked for. Now, that doesn't appear to have made its way into the advisory document that we've just looked at, but just looking at this, I think it follows from everything you told us yesterday that you would, at the time, have profoundly disagreed with the view being expressed here that it was for a clinician to decide in every case whether to communicate the results of the test to a patient. Your view, as I understand it, was that absolutely every patient needed to be told.
Well, I would have very strongly disagreed if I'd been at that meeting. I mean, I think if a patient has a blood test, they need the results of it told to them as a matter of right. But secondly, there's all the implications about possible sexual transmission. So it seems inconceivable, frankly, that a group of doctors could sit round a table and say, well, you don't really need to give the result unless the patient asks for it. I mean, 30 years down the line, this seems an utterly bizarre meeting.
And you've rightly mentioned the health implications in terms of the risks of sexual transmission if a patient is positive but does not know. Presumably in the context of patients with bleeding disorders, who these were the cohort of patients being discussed here, there are further possible health implications if you're having a bleed and a member of your family is helping deal with that. Transmission of HIV through that route.
Of course. I'm not sure, by the way, looking at who was there, why they've got so many BPL people there. That's an unusual thing to do, to have people from a company at a meeting of the reference centres, unless there was a major agenda item about BPL expansion or something.
I think that not specifically, but that may be an issue that we'll need to explore with those who were there in due course. Now, before moving on to events from 1985 onwards in terms of your own care of your patients, I want to ask you a few more questions about the issue of consent and provision of information to patients, and then a number of questions which the representatives of core participants have raised with me to explore with you arising out of your evidence yesterday. So we will be going back to a few of the topics from yesterday and then moving on to events from 1985 onwards. Just dealing broadly with issues of consent and the provision of information to patients, would you accept that as a matter of principle, whether to take the risks involved in a treatment, and in this context the risks would be the risk of developing liver disease or the risk of being exposed to a new and potentially fatal disease, or whether to take the risks of not being treated, which, as you pointed out, in this context could involve risks in relation to hemorrhage. That is ultimately a judgment for the patient. Would you accept that?
Yes, but I've said to you already that was the choices I gave them, and they were choices. I said to them, I'm your doctor. This is a very difficult time. We've got important decisions. This is what I think. I'm your doctor. I mean, many of the patients I had this conversation with, when I said, what do you think? They said, you're the doctor. I expect you to tell me what to do. Now we're in a different world where, quite rightly, this is a car being driven by patients. But there was passivity in the air to a certain extent Remember, these people, it's a congenital disease, inherited disease. From their earliest memories of coming to a hospital, somebody in a white coat gives them an injection that stops them bleeding. They were a very different, by and large, a different group of patients from gay people with HIV, who I looked after, who tended to be much more, I generalise of course, but the gay patients with HIV changed the nature of practice in the sense that they in many ways were a new generation of patients who came along to doctors quite rightly and said, hang on a minute, this is my life, my illness, I want all the facts and I want to do all the decisions, all of which is completely correct. So I'm just trying to get across to you, there were several patients when I had this conversation, you can only say they were bemused. They said, well, why are you asking me? Because, I've been a patient of yours a long time, I've been in the centre all my life, I don't know what to do. I rely on you to tell me what to do. And I would say, well, I'm giving you the choice. And they would say, well, I'll do what you think I should do.
But that choice was so important to give in this context. And I understand, indeed, your evidence, in particular in relation to the switch in the middle of 1983, is that you gave that choice to your patients. But the choice was so important, even judged against the standards of the 1980s, because it was their body, their health, their life, their death.
I agree.
And as you've just alluded to, in order to make that choice, they would need to be given information, potentially advice, potentially clear recommendations, but at the very least information by their clinician.
Isn't that what I said to you?
Yes, absolutely. I'm just trying to establish as a matter of principle, even in the 80s, and we know that in many respects...
This has nothing to do with medicine being more paternalistic. These standards should have applied then.
Now, in relation specifically to testing now, not for hepatitis C later on, which we'll come to, or HIV in 1984, but the array of blood tests that would be done on what I think you described as the regular full review that your patients would have. And I'm not going to distinguish here between Guy's and Margate unless you tell me that there were different practices when you were there. What were the tests typically that would be undertaken at a regular review of that kind?
So these would be done about every 3 months, sort of part of a comprehensive care review, as we talked about. And they would always include a check for this inhibitor. So about 10% of patients with haemophilia develop this antibody, which neutralizes the factor VIII. It's a very important and negative development. So that would be number one on the list, would be an inhibitor test. We'd just do a general blood count to make sure they hadn't become anemic because of bleeding. We might check their iron levels if there was any suggestion that they had been bleeding significantly. That we would check at that stage, depending on which date we're talking about, I think early 1980s, hepatitis B vaccine became available. So we'd be monitoring their hepatitis B status. And if they were hepatitis B negative and hadn't been exposed, didn't have hepatitis B antibodies, we would be offering them vaccine if it was available by then. And then we would be screening them regularly to make sure that the vaccine was still producing antibodies. So that's the hepatitis B part. And then these indirect markers for non-A, non-B, we haven't got a hepatitis C virus to test or level. So for every visit, we'd be monitoring their liver function tests. But we now know, as we discussed, that the differing results we got actually didn't really help us because they weren't actually a direct sort of predictor of what the state of the patient's liver was like. But we'd certainly be looking at their liver function tests. And I guess a general sort of wellness check, the body electrolytes and a blood sugar, that would be it.
And in relation to the liver function tests that you would be looking at, leaving aside the fact that you may have learned later that they weren't the best predictor, at the time you were looking to see whether there were abnormal liver function results. If there were, is that something you would expect to discuss with your patient and explain to them the significance or otherwise, as you then understood it to be, of those results?
Well, yes, but I mean, it was clear then that nearly every patient who'd had factor VIII concentrate from a commercial origin was going to have this non-A, non-B. We had one patient with hepatitis B, but nearly all the other patients, if they were regularly treated, had abnormal liver function tests, and they were aware of that. I told them that, and they knew we were monitoring it, and they knew about the concept of non-A, non-B, but they knew there wasn't a specific blood test, and I would say to them, and the Haemophilia Society would publish that, the presumption is you may have this third virus, and one day we hope that we'll be able to do the blood test.
And that would feed in then potentially to, as you said yesterday, the lifestyle advice that you might give.
Yes.
Would there be, this is now talking about testing more broadly, testing for whether it's HIV or hepatitis B or obviously later hepatitis C. Can you think of any circumstances in which you would have thought it right to withhold that test result from a patient for any significant period of time, unless it was a patient who lacked mental capacity, but we're not dealing with patients within that category. So from your own perspective as a clinician publishing then, can you think of any circumstance in which you wouldn't be telling a patient that they have tested positive for HIV, hepatitis B or hepatitis C?
No, I cannot.
Can I then just ask you, again, these are just a handful of questions about various consent issues as they emerge. We know that, and you referred to it yesterday, centres sent data to Oxford at the time, later to Manchester. And although we haven't seen it from the documents we've looked at with you, Dr. Winter, we've seen from other documents that data was not just the material we looked at with the overall amount of concentrate, but really quite detailed information about individual patients, patient names, dates of birth, status, and so on, in terms of their treatment. That was, as I understand it, material routinely sent by centres to Oxford in the early days.
It was sent once a year.
And that was at the beginning of each year?
At the beginning of each year.
I'm not expecting you to be able to speak for other clinicians in relation to this, but in terms of your own practice, were your patients made aware by you or your guys, your colleagues, that data was being shared with Oxford and later with Manchester?
The Haemophilia Society had said to patients in their publications, this data, it's extremely important that it should be centralised at Oxford, so we have a national database, and it's going to give doctors invaluable information about how many people with haemophilia do we have in the country, how many are severe, what percentage have inhibitors, how many are on home therapy, how many are on prophylaxis, how much factor VIII is being used every year. And they published, when you registered with the society as a new patient, this was part of the information that was given as, welcome to the world of haemophilia. This sort of activity does go on through the doctors, and they supported the doctors in that enterprise, which was seen as being very important.
Yes, and I'm not seeking to criticise the exercise, just to explore what patients would have known about it at the time.
It certainly was not the case, obviously. No, the patients were not individually approached and asked to sign anything then, which in later years they were, nor, of course, were they asked to sign any consent to having factor VIII. It was never considered necessary to ask a patient to give signed consent for that. All of that came later.
And in relation then to patients knowing that information about them was being sent to Oxford for these various purposes, is it the case that did you work on an assumption that they'd have known that because of Haemophilia Society publications, or did you have any conversations yourself with patients about that? Because I'm conscious most patients may have been members of the Haemophilia Society, but not necessarily all, and not necessarily all would have read material provided to them.
Yes. So each patient on diagnosis was registered with Oxford, given a designated code, and was issued with a booklet, a small booklet, like a diary, that had their name, their UKHCDO registration number, and they were instructed to always carry this book with them wherever they went, and most importantly, always take it wherever they were, because if they had a car crash one day whilst they were on a day trip to Brighton, this book would be found and the doctors in the hospital would be able to see it and know that they were a patient with haemophilia. So every single patient had this booklet, and it had their name and their registration number in it.
And so are you able to be fairly confident that your patients were aware that information about them was being sent on a regular basis to Oxford?
I have that confidence for my centre.
One of the observations you made in your evidence, I think, to both Archer and to the Penrose inquiry, when you were exploring the issue of different medical culture, clinical cultures of the 70s and 80s, you made some observations about the way in which haematologists of an older generation would have been trained as compared to haematologists of your generation and onwards. And could you just explain to us, please, what the issue is that you were raising?
Yes, I mean, this is an observation that came out of my Macfarlane Trust, which we may talk about later in the day, because my feeling is that I had insights that other doctors didn't get, because I was having to interact through the Macfarlane Trust with every centre in the country. So my major role at Macfarlane Trust was a patient who was a registrant of the trust would apply for help. I need a chairlift. And my role was to contact the haemophilia director and ask for a report, how, please give the relevant background information. Plus, running regular haemophilia residential seminars was a very powerful experience. You'd sit in a room on a Sunday morning with 10 patients from different centres. You'd be talking about one topic, and you'd be utterly bemused by the different way in which 10 patients could be treated by 10 different doctors. I mean, it was astonishing, and something that will surely come out of this inquiry is the great variability of care that patients receive. We've already heard how variable was the way in which haemophilia doctors arranged for testing. We've already heard about the variability in which haemophilia doctors told the patients their test results. We've heard about the variability of switching to safer treatment. And I developed a view. You should ask this to the doctors that follow me. I know that some of them don't agree with this view, which I've expressed previously, but I will say it as follows. I did feel that you could split the haemophilia centres, obviously, into centres that were doing as well as could be expected in a very difficult time, and centres that were doing things that just seemed inappropriate and not very appropriate. And developing this theme, some centres, like St Thomas's and ours, their philosophy was haemophilia is a very rare, complex, specialised disease. We want to know you as a patient, every single thing that's happening to you. So if you've got earache, you think it's nothing to do with haemophilia, but if you go to accident and emergency, somebody might operate on your ear without telling us and you'll bleed, or they'll give you aspirins which will bleed, or they'll give you an intramuscular injection which will make you bleed. So we would say, we want to be the filter for every single thing. Don't go to any other doctor ever for anything without coming to us. We might say to you, okay, you've got earache, we'll fix for you to go and see somebody, and then we'll communicate. So that's philosophy number one. Some centres, the attitude was, you'd ring up, I've got earache, nothing to do with the haemophilia, go and see a GP. So if you like, I don't know if there's a word in the English language that's the opposite of holistic. Some centres were holistic, some centres were not holistic. When you broke it down, my, I stress, controversial view is that I thought you could by and large relate it to the nature of the doctors. It was down to the doctors in that centre. And to eventually get round to answering your question, there was a very important change that happened in the about 1973, 74, in the way in which haematologists were trained. So before that time, if you wanted to be a haematologist, you did your medical training, you did your houseman's year, and then you went straight into laboratory medicine. So you never had any time on the wards really working as a doctor. You ran a haemophilia centre. You had patients who you spoke to about their haemophilia. If they had to be admitted to the hospital, they were admitted under a general physician whose name was at the end of the bed, and the laboratory doctor would go and see him. In 1974, quite rightly, because haematology was becoming so much more clinical, the Royal Colleges says we're completely changing training. If you want to be a haematologist, you have to do general medicine first, after qualifying. So I was the first, I think it was the first year, about 10 of us, we wanted to be haematologists. We could not go straight into haematology after the 6 years of training. We had to do at least 2 years of general medicine, and we had to do this exam, the membership of the Royal College of Physicians. So the importance of that was, in those 2 years, we were working as medical registrars. We were working with all the things that general medical wards bring, talking to sick people about very serious diagnoses, telling people they were going to die, being with people why they died. So if you like, there was a group of us who, for the first time, were a group of doctors who dealt with the sort of problems that HIV suddenly brought. The older doctors were really good laboratory scientists. They were fine as haemophilia doctors, dealing with the haemophilia. They'd got no experience of saying to somebody, I have to tell you, this test shows that you've got HIV, and this is a very serious thing, and your life might end, and then being with them while they got ill, and talking to the relatives, and all the things that we've seen that didn't go well in some centres. So I make that observation, but please do ask the same question to the other doctors next week. Who'll probably think it's not true.
I will. There's then just one document I want to show you. This is a later document. It's from 1995. There's just an issue about consent that's discussed, and I just wanted to ask for clarification as to what you think the issue was. Henry, it's HCDO 0000015_005. If we go to the next page, please. So it's a meeting in 1995, September 1995, of the centre directors. Dr. Colvin is now the chair. We can see the bottom of that list there that you were present. If we go then, please, Henry, to page 5, paragraph 8. You may have no recollection of this, Dr. Winter, but you're the first person I can ask about it. It's under the heading Consent for Treatment. I'll just read it out. Dr. Colvin said this matter had been raised at the Regional Directors Committee meeting. Agreement had been reached in principle to formal written consent for first treatments with concentrates, and also that perhaps further consent should be obtained when there was a change in the product used for treatment. There was no uniform agreement about this. Dr. Hill said that consent needed to be informed consent. He thought there was a need for a standard form. Dr. Colvin said that the Executive Committee could prepare a form if required to by the AGM, but he thought it might be difficult as NHS trusts have differing policies. Dr. Ludlam suggested the matter should be reviewed again, etc., etc. Dr. Savage said he felt that legal advice should be sought about this matter. And then this. Some directors did not agree that written consent should be obtained as they felt that this could be held against them. And then it says it was agreed the directors accepted that informing patients was important, but there was no agreement as to whether or not written consent should be obtained. So we can see the context there is the issue of whether there should be written consent and standard consent forms in relation to treatment with concentrates, either for the first time or change in product. But I just wondered whether you were able to assist with the suggestion that some directors apparently expressed at this meeting that written consent, they didn't agree written consent should be obtained as they felt it could be held against them. Do you know what concern underpinned that? Why did people think written consent could be held against them?
I don't. I mean, I do remember these meetings because it was around this time, with the changes of medical practice, we began to say as an organisation we should surely be, getting signed consent at the start of each process. When we get a new patient, they should give signed consent to comprehensive care packages. We should get signed consent for the first treatment, and we should get signed consent for the data that was being sent to Oxford or then Manchester, and we should get signed consent for any change of treatment. And my recollection was that there was a sort of consensus, but as usual there were a few outliers who had reservations, but I don't recall. It doesn't seem intelligible, does it? Why should asking a patient to sign a consent form be a problem for the doctor?
There may be a school of thought that thinks that consent is more than a question of process, legalistic, formal process, but is a reality which depends upon the degree of information which is given and the relationship between the patient and doctor.
Yes.
And it might see the need for paperwork and signatures as being consent, as simply a concentrating on process rather than reality.
Yes.
What would be your view on that?
Well, my only recollection is that, if I've not been aware of this view to my recollection, and it's not really a view that I can find any empathy with. It seems to me if I ask a patient to sign consent, that's a good thing for me as a doctor. It's saying, if you like, I've explained this situation to the patient, and he or she's put pen to paper saying, I agree to what Dr. Winter is asking me to do.
Now, the critical thing about that might be that you had explained it to the patient.
Yes, that's what I mean.
Rather than simply obtain the patient's signature.
Exactly.
Yes, I see.
So, Dr. Winter, as I said a few moments ago, I'm going to ask you now a handful of questions arising out of your evidence yesterday, which are requests for clarification or a few further matters to explore that have been put forward by the representatives of core participants.
Sorry, can I ask you who are the core participants?
There's a whole range of them. We have the largest number of core participants of any public inquiry. Many of those who were infected or their relatives, but also health bodies, government departments, and the like.
Can I help? Essentially, it's a question of what's in the rules that govern inquiries, but the core participant is someone with a very particular interest in the inquiry, either because they have an interest in the outcome or because they played a real part in what took place. Something along those lines.
So the first matter I wanted to ask you about is just the developing state of knowledge, or the state of knowledge about risks from American concentrates and the basis for that, and then the developing state of knowledge about possible risks from British concentrates. So you alluded to this yesterday, and I think you, as I understand it, there was a general understanding that American concentrates posed a risk in terms of transmission of hepatitis viruses because of the two factors: pool sizes, large pool sizes, and the paid donors from whom the plasma might be collected. Is that right? That was the basis for concern about the American concentrates.
Yes.
Yes, and you, for that reason, your preference had been, as between the two, you'd rather use British concentrate than American, and you told us yesterday about the supply problems with Elstree and Tooting that meant there were shortfalls. And then when you were talking yesterday about the decision-making that you were then taking when we get to 1983, 1984, you talked about there being an awareness, certainly for you and Dr. Savage and the other group who made this decision in 1984, that you couldn't assume that British concentrates were safe. Could you just explain how that that fear, that concern developed, what was it that led you to understand that both sources might pose dangers rather than simply the American?
So let's use hepatitis C as an example and the knowledge that we later developed about hepatitis C. So here we are, here's this highly vulnerable group of patients because of the nature of the concentrate process. 20,000 donors. If one of the donors is positive, patients may get infected. So we now know that in the 1970s, the incidence of hepatitis C in US plasma was what, 1%? So let's do the maths. If you were a British haemophiliac attending a British haemophilia centre on regular treatment in the 1970s, after the concentrate had become available 73, 74, a doctor gives you an injection of factor VIII from paid donors in America, 1% of whom have got hepatitis C, and it comes from 20,000 blood donors, you're probably getting maybe 200 different hepatitis infections. We now know that the incidence of hepatitis C infection in British blood donors was much less than that, but it was still about 1 in 1,000. So instead of being exposed, getting 200 doses of hepatitis C, each injection, you might be getting 20. So, which is no better than 200. So this was our major concern. We accepted that British factor VIII was likely to be safer than American, but still not safe. And of course, we were, if I may say so, we were right, because it turned out that some British concentrates did transmit HIV.
And you talked about how patients had a general preference for British over American, if they could have that. What was the first time, roughly, you think that you would have explained to patients that British concentrates weren't necessarily safe? Would that have been when you were doing the heat-treated?
Yes, that was at the chemo. I mean, this was a conversation you always had at these seminars and the weekends. You talked about the nature of concentrates and where they came from and commercial and the need for self-sufficiency. These were very, very regular sort of items that on a Sunday morning would be discussed in one of these workshops. But the key moment for me was this switch to heat treatment, because it was a reversal of the preferred system.
And then looking at the period in the late 70s, early 80s, where hepatitis is the main concern. I think you were candid yesterday. You and your colleagues were not hepatologists. You were not virologists. You were haematologists. To what extent, in either Guy's or Margate, in this period up until sort of late 70s, early 80s, was advice sought from hepatologists or virologists by centres such as yours?
Well, it was sought. I mean, the UK HCDO, as you said yesterday, they did have a liver working party at that time. So they were doing those interactions and taking advice. And they would have passed down anything to us in terms of specific recommendations. I think there was a feeling that, hepatitis B we could identify, and we knew about that. We were monitoring the liver function. We believed at that time that we could see whether somebody was clinically well, fine, and we had a belief, subsequently untrue, that we could monitor somebody's liver function by looking at their poorly named liver function tests, which don't, we now know, reflect liver function. And we had the theory, as we talked about, of non-A, non-B, and then the liver biopsy findings of Professor Preston, but there was no therapy. I think this is a key issue in answering your question. There was no great move at that time to have people automatically reviewed by a liver specialist. That came later, and that was driven by the advent of Hep C testing, but most especially by the availability of treatment, because haemophilia doctors did not have the expertise to make a decision should this patient have interferon, which was the first of the hepatitis treatments. So no, I don't think there was. As long as the patient, if I had somebody who was jaundiced, with and who wasn't well, and their bilirubin was getting worse, I would of course refer him to a liver specialist.
When you gave your evidence yesterday after I played that first extract from the 1988 documentary, your comment was that you didn't have any regrets about having said that, and I've been asked by a number of people to ask what you meant by that, by not having any regrets about what you said. Did you have was there some form of criticism of you for making those comments?
You'll have to remind me what I said.
I'm going to have to remind myself. And I think the first extract was an extract in which you talked about the knowledge about American concentrates and the potential risks from American concentrates and the general state of knowledge in relation to that.
Yeah. That sounds all right, doesn't it?
Yes, I know, absolutely. I've been asked to ask you what you meant by saying no regrets. Do you mean that's still your view?
I've listened to myself looking much younger 30 years later, and I've listened to what I've said, and I haven't looked at it and said, oh, I wish I hadn't said that.
Thank you.
I, obviously reassured to find that what I said sounded reasonable.
And then I just wanted to ask you about the phrase you used yesterday and again this morning about presumptive non-A, non-B hepatitis. What did you mean by that?
Well, again, we've talked about this. We didn't know what... We invented that phrase, but we didn't know what it meant. I mean, theory number one, which turned out to be true, was that it was just hepatitis C. But there was a lot of talk about could it be several viruses. We subsequently got hepatitis E and whatever. So we didn't know whether we were dealing with, whether it was all one disorder or could it be several, that's why I've used that word. Because in theory it could have been one virus, hep C, or it could have been an array of viruses, all of which were non-A, non-B.
Was it your assumption by the late 1970s that, and I'm looking at what you knew at the time rather than what you now know with the greater knowledge that you have, was it your assumption then, do you think, that many or most of your patients had non-A, non-B, or was it just a concern that they might have?
I thought from the moment from about 78 onwards, that every single patient of mine who'd had factor VIII concentrate had hep C, for all the reasons we've just discussed about the risk of being exposed to donors. We had all this data by this stage of infectivity rates of American donors. I mean, indeed, going back to Garrett Allen, the late 1960s, of all the risks of commercial donations compared with voluntary donations in the US. So I was completely signed up at a very early stage that, I was working on the assumption that any patient who'd had factor VIII had hep C or had non-A, non-B.
And I know I asked you about this yesterday, you couldn't recall what you told patients about the risks of that, although you agreed that they should have been told, but you couldn't recall what you'd said to patients over 40 years ago. Do you recall whether you told patients that you thought they probably had non-A, non-B hepatitis? Did you use that term with your patients?
Well, very much so, because we talked about the monitoring of liver function, and part of that package was to say to the patient, as you know, your blood tests include these liver function which are abnormal, and this is because, as you know, you haven't got hepatitis B or A, you've got this third virus. And in the early years, that would have been, accompanied by a phrase, you're very well and you're doing very well, and I know you're very pleased with the concentrate treatment, and we're monitoring it. And then later on, after the Sheffield data, we'd have started to qualify that with, we are looking significantly at this because there's some evidence that some people might be getting or might get sick in the future with this hepatitis virus.
Now, I asked you yesterday about...
Just before we move on, can I just be clear about your use of your word presumptive? Because it seems to me at the moment you may have used it in one of two different senses or both. In your answers to counsel, what you've said is that it was presumptive non-A, non-B, presumptive hep C, because there might be other viruses, and so one presumed it was an entity, non-A, non-B, presumptive in that sense. The other presumptive was your reflection on what the patient might have, your assumption that whatever non-A, non-B was, one or more viruses, they had it. Yeah. Now, which one was it, or was it both?
So you've done there's something going on with the loop system.
Ah.
If you could, I think it was you leaning. If you could
sorry,
lean
my fault. Which one was it?
You've cured it. Yes, I've heard you.
Or was it both?
There's just a lot of interference suddenly.
My fault, sorry.
No, that's fine. I think what I was trying to say to a patient was your blood tests show a pattern suggestive of viral hepatitis, number one. Two, that hepatitis is not hepatitis A and it is not hepatitis B. So here's the presumption. You have a third type of hepatitis, which we're calling non-A, non-B, but we don't really know anything else about that virus or viruses at the moment. That was the presumption.
And the assumption was that most patients had it because if they'd had commercial concentrates.
Yes, on two bases. Firstly, for all the sort of statistical reasons we've discussed, if they'd had factor VIII, it'd be extraordinarily unlikely that they wouldn't have it. But then secondly, if they had abnormal liver function tests for no other reason, they didn't have hep A or B and they went an alcoholic, that would make you even more certain.
Thank you very much.
I'd asked you yesterday about Chief Medical Officer guidance, and I'll come back at a later stage today to the absence of overarching guidance in more detail. But specifically in relation to Chief Medical Officer guidance, we know that from time to time the Chief Medical Officer, for example, issued what were called Dear Doctor letters.
Doctors, yes.
Was the expectation at the time that if the CMO issued a Dear Doctor letter, that doctors would comply with whatever was being said?
No, I don't think we worked at that level. I think, you see, we had the Department of Health had a doctor who was designated to attend UKHCDO meetings. So we had a link, a formal link. And I think it would be fair to say we were always, I'm sorry to say, pretty frustrated about the nature of that link, because we had wanted and expected that medical link would go back to the DOH and put a bomb under them, basically. We expected they would go back and say, there is a very serious situation in haemophilia, and there are some very important things we need to do. One of them is absolutely putting as much funds as quickly as possible towards self-sufficiency. The other thing is making sure we've got communication networks open with transfusion centres, and also that we're issuing appropriate directives to haemophilia doctors on a much more formal basis. So I think that all the time I was a haemophilia doctor, by and large, we were always very frustrated by the lack of DOH involvement. These doctors changed regularly. I'm sorry to say they didn't seem particularly interested or motivated. It was, we went to them with all sorts of issues. Could we have more cryoprecipitate? We need more funding for concentrate. We want to switch to heat treatment. What's going on with self-sufficiency? Where's the recombinant factor VIII? And each time the response was nothing like as dynamic or helpful as we would have wished. And again, Dr. Colvin next week, who was chairman of the organisation, he would have had those links more closely than I, and I would wish to have his view.
Yeah, and I absolutely understand that as a matter of fact, there was potentially limited guidance coming out of the Department of Health. But in general terms, dear doctor letters from the Chief Medical Officer, were they, as far as you can recall, I know there weren't any on the issues that we're talking about, but were they generally materials that doctors would expect to comply with?
Oh, very much so. If the Chief Medical Officer wrote a Dear Doctor letter and it was an area of medical activity that you were involved with, you would expect and be expected to follow it.
Thank you. And then a very specific question about a particular form of test that we have seen some evidence that some patients underwent in 1983, possibly 1984. Some have recounted to the inquiry in their evidence that they were given some form of skin prick test in the late 1980s, okay. In relation, in some respect, to monitoring for signs of AIDS. Do you know what that would have been, or was that a practice that you were familiar with?
I'm not familiar with it. This seems to be something very inappropriate, but you could test for somebody's, it was perceived that you could test for somebody's immune function. There's a limb of immune activity called cell immunity, and as I recall, you could assess somebody's cell immunity by some sort of patch test on the skin where you provoked with, like allergy testing. And the gay patients who'd originally presented with AIDS, they had some of these features of suppressed immune function, hence the pneumocystis pneumonia as well. I've never heard of that being done for people with haemophilia. It was not at all a good idea. It was certainly not going to give you any accurate information, and it was certainly not going to tell you whether you had this virus or not.
Thank you. Then moving to you taking up your post in Margate, do you know why your predecessor, Dr. Sterndale, was leaving? Was it just routine retirement, or
yes,
were there other it was?
He retired.
Okay. Yesterday, when you were talking about providing information and advice to your patients who had tested positive for HIV, you talked about the sexual health advice that was given, the risk of transmission, and said that was the first time haemophilia clinicians had to give such advice to their patients. What about sexual transmissibility of hepatitis B? Because that was known to be a risk. Is that something you were aware of and had to counsel patients?
Well, I only had one patient who had hepatitis B, and I had spoken to him.
And about that, the sexual transmission? Yeah. Are you aware of any practice in any centre of which you have any direct knowledge of taking blood samples from patients with bleeding disorders for the purposes of research into either the development of the hepatitis B vaccine or any other forms of research?
I am aware, I was taught by my professor at the Middlesex, always a good idea to take an extra vial of blood and store it. You never know when it might be useful. He did that with all of his patients. He had a vial of Winston Churchill's blood, I remember. And that was a practice that was followed in a small number of centres, and as in one particular instance at the Royal Free, came to provide extremely important information. But there were some centres that did. This wasn't an extra blood test. It was while these routine bloods were being taken, some centres, I'm sure without saying anything to the patient, just filled up an extra ampoule and froze it and held it in deep freeze for long-term usage for a research purpose.
And do you know, if you don't, please feel free to say so, but do you know whether any of those research purposes included any work on development of the hepatitis B vaccine?
I've never heard of that, but I've certainly heard it used for other purposes, which we'll talk about.
Which were what?
Well, Dr. Kernoff's work. Do you want me to talk about
Yes,
that? Or-
please.
So they're all free with 100 positive. So let's go back to where we started this morning. The balloon's gone up. The world has changed. It's October 1984, late October. The results are in. So at the Royal Free, you're going to get Professor Christine Lee, who was part of that team. You can ask her. They've got at least 100 positive patients. At the Royal Free, they did what we talked about. They had stored blood. So the director at the time, or co-director, Professor Peter Kernoff, did the obvious thing in the terms of he then retrieved from the deep freeze the samples on all of the patients who were positive and tested them for HIV. So this was an you can argue about the morals and the ethics of he should have told the patients he was doing it or whatever, but this was a quite extraordinarily important exercise because there were two very major observations. Firstly, when he started to do the retrospective testing, all his 100 patients positive in October 84, all of them had been positive for at least 3 years. This was not a new virus in the blood supply. This virus had been in the blood supply for 3 years. The patients had been infected for 3 years. If you extrapolate that to other patients around the country, the haemophiliac unknowingly had not been taking any precautions. The doctors and nurses in the hospital had not been taking any barrier precautions. They didn't know the patients had this unknown virus. So that's the first extraordinarily important observation. The second extraordinarily important observation was when he got as far back, I think, as 1980, 1979, the tests were negative. So this was the second. Can't stress the importance of this work. It told us HIV seems to have entered the blood supply around 1979 to 1980. Now, this has got immediate, major references to Dr. David Owen's initiative. I might as well go on to say this now. I might as well go on to give my whole sort of overview of the virus changes over the years. If you look at, we've just been talking 10 minutes ago about the chances of getting hepatitis C in American donors compared to British donors in the 1970s. And I've said to you, even if Dr. David Owen's initiative had been successful, let's say it's 1978, and we've gone from a high Hep C incidence, 1 in 100, to a low Hep C incidence, 1 in 1,000, for concentrate manufacture, it's voluntary donation, it's still 1 in 1,000. So if you're a British haemophiliac in the 1970s, on self-sufficiency, voluntary donated, you're still going to get Hep C. So my major conclusion, number one, of the two epidemics I see as being different. I see the hepatitis C one, if you were a regularly treated patient, it was inevitable that you got hepatitis C. You probably got many hepatitis C infections the first time you ever had factor VIII. And that lasted all the way through, even if you then went on to British only, and even on the first generation of heat treated. They all transmitted hepatitis C. So until about 1985, 1986, when the second generation of heat-treated concentrates came through, if you were a haemophiliac patient in Britain and you'd had factor VIII once, it was extraordinarily likely that you would have hepatitis C. So the major conclusion from that is, I do not believe, from my experience, the hepatitis C epidemic was avoidable in regularly treated patients, a key phrase. If you were a patient who'd hardly had, it's 1985 and it's your first ever injection, that's different. But for regularly treated patients with severe haemophilia, this catastrophe could not have been avoided. With HIV, my own view is the situation is different, because Dr. Kernoff's work tells us that HIV, reported as a disease in 1981, doesn't seem to have been in the blood supply until 1979-80. And we now know from the Scottish experience, self-sufficiency, when HIV broke, they had very little HIV infection, less than 10%. So if Dr. David Owen's initiative had worked, as it was tantalizingly close to doing, if in 1979-80 we had been self-sufficient at a time when HIV entered the blood supply, we wouldn't have been relying on a high HIV infection pool, we'd have been relying on a low HIV infection pool, like the Scots. So I think it is tempting, this is all medicine's dangerous retrospectively, but it is tempting to speculate that if Dr. David Owen's initiative had worked, the experience in England would have been similar to Scotland, and we would have had maybe 10%, same as Scotland, instead of the catastrophic 90%. So that's my generalized overview. Obviously, when I was thinking of the things that I would wish to say to you in giving my evidence, these are some of the most particular things I would wish to say to you. I think these two virus epidemics, which were both catastrophic, are different. You should look at them in different ways. And I think the hepatitis C was generally, for most patients, unavoidable. I think that very poignantly, I think if Dr. David Owen's initiative had worked, you have to think things could have been very different.
Thank you, Dr. Winter. So I note the time, and I've run over in my questions into the break. So is this a convenient moment to take the break?
Yes, it is. We'll take a break now until 12 o'clock.